afternoon, everyone. This is Rochelle Seeger. I'm here at the Foundation for a Healthy Kentucky. I'm honored to work here at the as a Community Health Research Officer for the Foundation, and I work on the data initiatives here at the Foundation for a Healthy Kentucky. And this is a great part of my job. I get to plan and host the Health for a Change webinar and workshop series. The Foundation for a Healthy Kentucky began this training series in 2011. And the effort was just this, to support those people working across the state of Kentucky to improve health. So we have training workshops on grant writing, advocacy, coalition building, infographics, and this webinar on evaluation. So first up, I want to be honest with you. Last fall, we did a training on advocacy evaluation, and I was super nervous. Who's going to show up to an advocacy evaluation workshop? Really? Well, I've learned a lot. I learned that that workshop was sold out. We had a great crowd of people. It was held at the Northern Kentucky Health Department who were interested in learning this topic, interested in learning how they could do better at their advocacy work, how they could track and measure that work in evaluation. So thankfully, I'm so glad all of you have joined us today because, again, our topic is evaluation. Here at healthy-ky.org, if you check on the Foundation's website under the Events tab, you can find recordings and slide decks from all of our past events. You can also see the upcoming events there on the website as well. First, I want to tell you about the Foundation for Healthy Kentucky's mission. The mission is to address the unmet health needs of Kentuckians, and that's a photo I took earlier this summer in Whitesburg, Kentucky, where the foundation was hosted by Kane Community Kitchen and Valerie Horn, who does fantastic work there on Farm to Table, Healthy Eating, Double Dollars program in Whitesburg area. So thanks to Valerie for hosting us in Whitesburg. It was a beautiful event down there. The Foundation for Healthy Kentucky's mission is accomplished by developing and influencing policy, improving access to care, reducing health risk and disparities, and promoting health equity. And you can see even there the sign that says this is a tobacco-free campus is posted on our building here in Louisville to notify all of the people who come and join us here at the Foundation offices that we also have a tobacco-free campus here for our workplace. As I mentioned, healthy-ky.org is the Foundation for Healthy Kentucky's website. You can find out about our current initiatives, upcoming events, research and data, including another piece of the Foundation's work I oversee, the Kentucky Health Issues Poll. And you can also sign up to join the Foundation's email list there at healthy-ky.org. One more announcement before we get started with the main event with our 3 Kentucky-based evaluators. Upcoming Health for a Change events in this training series. This training series for Health for a Change this year has reached 500 Kentuckians in counties, in 75 Kentucky counties. So I'd love to see where you all are calling in from. So if you want to chat in your response there, if you're logged in, chat in what county you're calling in from in Kentucky. Also in that chat box, you can send our presenters questions that you're interested in hearing the responses to. If we don't have time on the webinar today, we'll follow up with you about those responses. So please chat in your questions when you have opportunity, and if you want to share with us what county you're calling in from. Oh, I see Adair County, right on. Thanks for joining us today, a bunch of folks from across Kentucky counties. Our next webinar will be next week, Monday, and it's a webinar on e-cigarettes. All the information about registering for that's on the website. December 3rd, we'll have another webinar on e-cigarettes, talking about teens and e-cigarettes. And finally, December 4th, we'll have an in-person workshop with Jessica Bellamy on infographics. That'll be here in the Louisville office of the Foundation for Healthy Kentucky. Another associated event, the Bounce Coalition, will be hosting 2 trauma-informed trainings on adverse childhood experiences. Those will be held in partnership with Bellarmine University. That's upcoming this Friday and also on November 1st. A reminder that you'll get a copy of the slide deck will be posted to the Foundation's website in the next day or so. Finally, please save the date. The Foundation for Healthy Kentucky and Interact for Health are pleased to present Data Forum Fostering Health Innovation in Kentucky and Ohio. We have a great lineup of speakers. That conference will be held Friday, November 15th in Erlanger, Kentucky at the St. Elizabeth's Training Center. I'm so excited to have 3 Kentucky-based evaluators on our call today to share some of their experiences on the work that they do for different types of evaluations. We have 3 presenters. Each will introduce themselves and tell about their work and share with you some of the evaluations that they're currently working on. We may have time for questions, so please feel free to chat in your questions. Reminder to everyone, you will get the recording and the posting of the slide deck very soon. Our first presenter today is Dr. Melissa Abadi. She's with PIRE based here in Louisville, and I'm glad to turn the call over to Dr. Abadi. Welcome, Melissa.
Thanks, Rochelle. So I'm Melissa. I'm a senior research scientist at PIRE Louisville, Pacific Institute for Research and Evaluation, and I'm co-presenting today with Kirsten Thompson, who is an associate research scientist at PIRE Louisville. And today we're going to talk about a pilot study that we recently conducted that was funded by the FDA and NIDA to look at e-cig use and environmental context of use. So we decided to go for an RO3 mechanism for this particular study because we submitted back in 2016 and we didn't know a lot about youth e-cig use then. We knew even less than we do now. And so we designed a study to find out how kids were using e-cigs, the devices they were using, the flavors they were using, how often they were vaping, where they were vaping, and why they were vaping, looking at motivations for use as well as exposure to others' use and to tobacco marketing. And so we designed a pilot study to answer these questions and inform FDA policy around the sale and distribution of e-cigs. And an RO3 mechanism is really perfect for this type of study because they support small research projects that can be conducted in a short period of time. So what we have here are the sections of the application and of our study, but given the focus of this webinar, we're focusing on the approach and study design, the survey measures, our human subject protections that we set in place, as well as our recruitment protocols. And then at the end of this presentation, we'll be sharing some of our findings from the pilot. So we wanted to conduct our study with youth because, as we know, the effects of tobacco use disproportionately affect those who begin using under the age of 18. They're at greater risk for addiction, greater use for substance use problems, and other health risks. And they're also the most vulnerable population to tobacco marketing influences. We chose a method called ecological momentary assessment, which basically means daily surveys that ask questions about use and motivations and the environment during which they were using. We sent a link with a survey on cell phones. We used this particular approach because it reduces recall bias. So in other words, using this type of approach where we ask youth about behaviors and motivations daily is more accurate than surveys, even national surveys like YRBS or Monitoring the Future that ask about past 30 days, which is harder to recall. We recruited past 2-week youth e-cig users. We did this because we wanted to be sure that there were some youth behaviors during the 14-day study period so that we really could look at associations to see what was helping to predict use. And this led to certain screening requirements, which required a good amount of time, and we'll get into those protocols and challenges later. So given that this was an RO3, we had a compressed timeline to develop our survey design, our measures, and our protocols. So we didn't start recruitment until the second half of year 1, and we finished recruitment at the end of, or that second half of the first half of year 2. So again, at the time we didn't know a lot about e-cig use, and so a lot of the survey development we were going around to vape shops and asking about device characteristics and asking, you know, what types of youth were using, why they were using, if they were also tobacco users. There weren't validated measures when we were coming up with our survey items, and so in many cases we adapted our survey measures from validated tobacco use measures on surveys such as Monitoring the Future or YRBS. And we had an extremely vetted process for survey development, calling in any experts who had previously measured e-cig use with this population to make sure that we were getting the information that we needed to. And so we collected a baseline survey, which asked a lot of demographics and socio-demographics, such as parent education, family structure, personal risk factors. And then daily, we asked youth about their e-cig use, their tobacco use, and their motivations for use, as well as any kind of intentions or willingness they had to use the next day. We also asked a lot of questions about the device characteristics, again, because we were trying to really learn about how they were using and what they were using.
So the human subject aspect of this project, obviously youth are listed as a vulnerable population. So that is one of the largest challenges in working with youth. There's often two levels of consent that are required. That's the parental consent and then the youth consent or assent. As a vulnerable population, you cannot ask youth anything related to substance use because they are under the legal age of use of either 18 for tobacco or 21 for alcohol. And these are considered illegal activities for them. And then there's also the aspect of privacy and confidentiality for our participants, which are the youth. So we could not reveal to the parent or the youth that the study was exclusively for users, so that we were explaining honestly what the study was, but not sharing that it was a user-only population. So youth who were interested had to give us their parental contact information up front. It was very clear right from the front end that we were going to have to tell their parents that they would be receiving $150 from us for full participation. They'd have a phone that wasn't theirs for a couple weeks, and that we were going to explain to their parent what they were actually doing, given that they were under 18 years old. So there was this back and forth process of youth giving us the information, contacting the parent, then contacting the youth again, screening the youth. If they were eligible, they would get an email that said they were eligible. If they were ineligible, they would get an email saying, thank you for your interest, but you are not eligible for the study. So after eligibility, we then would have to contact the parent a second time to get full consent, explaining the duration of the 2-week study, the incentives, and the phone surveys. So working with youth, a strong human subjects protocol is critical, but it's also a very timely process. The other aspect of a study that requires youth and kind of requires extra confidentiality and privacy, the recruitment, we recruited with adult parents who had youth 13 to 17 that were interested, and then we also recruited with youth that were interested, with them knowing that obviously we were going to tell their parent that they were participating in this study, so that they were going to need to give us parent contact information regardless. So we used social media, we used posts that were free, but we also used ads that we paid for. Same thing with Craigslist and Indeed. We realized that if we paid for the advertisements, they would stay on these sites for at least a week, and that would be better than the free ads that really they would drop pretty quickly from visibility. We depended strongly on word of mouth from parents and community members, because adults could sign their kids up, and then youth could also sign themselves up. Like I was saying, we had a website that parents or youth could go to and they could sign themselves up. Word of mouth became a really big thing. At first, we've done research all over the world and all over the country, but Kentucky is not a population that is necessarily used to this kind of research, so there was a lot of hesitancy from parents that they were involving their kids in something that wasn't real, and even from kids that were questioning if this is actually real, because we've kind of grown up in this generation of these clickable ads that claim that they're going to give you $5 for taking a survey. So there was a process up front of validating the study and making sure they understood it was real, but once it snowballed into word of mouth being A lot of kids had heard about the study just through school and other things, so it validated itself as time went on. And then in person, we really went to any place that was free or low cost and well attended by Louisville youth and also Northern Kentucky youth. So schools, festivals, fairs, different events, and also coffee shops and things of that nature where kids would be hanging out. Data collection, as Melissa was talking about, we had a baseline survey and we also had EMA surveys. So all of that work that we've talked about in the human subject protections and the recruitment, you have to remember we haven't collected any data yet. So finally, we get them through the process, they're screened, there's 2 levels of consent, and now we still have to get them through basically 2 rounds of data collection. So baseline surveys were administered online. Those took a good amount of time, 40 minutes, so we equated that to $15 incentive. We met with them to encourage study buy-in, but also we gave them that first $15. We explained the process, we signed the paperwork, we made sure that they understood this was real. They were going to get, their $150 if they did everything that we asked them to do. So they do the baseline, we meet with them, and then they get the phone, or they can use their own phone for the EMAs like Melissa was talking about. These are 5-minute surveys that were offered to them daily at minimum. However, on Fridays, we offered 2 surveys, and then on Saturdays and Sundays, we offered 3 surveys. Again, we did not know when their use would be highest, but we assumed their use would be higher during unsupervised times. So we gave them more surveys to see if we captured more use. And then the incentive that we offered was $5 per survey for $120 plus a $20 bonus, and then $15 for returning the phone and the charger. We were asked to discuss challenges and lessons learned. Again, until the last slide, we weren't collecting data yet. So all of that entire process is basically a huge challenge. The back and forth between youth and parents, we lost a couple participants that way. We even had a few participants that were eligible that got to the baseline phase and they never finished the baseline survey, so they were out at that point. I think in total we had 844 people interested in this study that got through various processes. We had almost 400 that were screened for eligibility, and ultimately we had our 50 2-week users that we used for the sample. The other large challenge and lessons learned was the technology. We used a fee-for-service text service that, for some unknown reason, shut down over Labor Day weekend, so we lost a couple days worth of data for 10 participants, and then we had sometimes, and this is an issue that you'll often encounter if you're working with rural youth, which half of our sample was, they would go in and out of Wi-Fi, they would go in and out of places where they had data, and sometimes the EMA surveys, especially on the weekend, would go to them in an incorrect order, and because they would kind of get 2 surveys at the same time or something like that when they came back in for data. So these were all issues that we kind of worked through and had to think about for the next study that we did.
So in the last couple of minutes, I'm just going to go through some findings related to our AIMS. We don't have a lot of time, so I'll go through these pretty quickly, but the slides are available on the Foundation website if you want to review further, and of course my email is attached if you have follow-up questions. But the findings I wanted to present today are related to our AIM-1, which is really exploratory, looking to determine e-cig use behaviors and patterns and characteristics of use. Again, we were just really trying to figure out how and why they were using and what they were using, but we also asked questions about access, beliefs, and exposure to marketing and others' use, as well as the motivations for use. And before I get into the findings, I see a question up here that asks, if 50 is a strong enough sample as an indicator of statewide use. And so first, I'll just mention that because we were using the methods that we did, because we were using ecological momentary assessment and we had daily surveys over 2 weeks, we actually were working with 700 observations instead of 50. And so that's another reason that we use this approach, was because we could conduct and test more hypotheses using the daily approach. And then if you considered all of the surveys that we collected, which was 24, we actually were working with 1,200 observations for our analyses. And then just the second part of that question, you know, we're not saying that this is an indicator of statewide use. This is a pilot study that will help us, you know, gather data to inform a larger, more representative study that would hopefully be more representative of the state and of other states like it. So just to talk a little bit about our sample, again, there were 50 youth, ages 13 to 17, 40% were male, so pretty evenly split on gender, 90% were white, and we had most of our participants at 17 years old. So 48% were 17 years old, 19% were 15 years old, and 33% were 16 years old. 96% of them, you know, again, remember we were recruiting users only for this particular study, and 96 reported that they had ever vaped nicotine. And we found out through additional follow-up that 4% were actually vaping nicotine without realizing it. They were using Juul flavored pods and thinking that there was no nicotine. 48% had ever smoked a tobacco cigarette in their sample. Importantly, by 14 years old, 46% had said that they had vaped nicotine, and 26% said that they had smoked a whole cigarette. So thinking about and looking at the vaping frequency and some of the context that we looked at, 90% said it was easy to get nicotine e-liquid. On average, they were vaping 7 times a day and 6 puffs per occasion. The highest use was on Saturday. The lowest use was on Monday. Youth vaped with their own device 55% of the time versus someone else's device. They vaped high nicotine content 46% of the time, which was 18 milligrams or higher. They were vaping with flavors 86% of the time, and they were vaping socially versus by themselves 70% of the time. And they also vaped in their home about half of the time. The most common reasons for vaping was that it feels good, they like the flavors it comes in, tobacco was prohibited where they were bored, and also they liked doing vape tricks. And so, again, because we were learning a lot about how to ask questions, instead of just asking them about their device characteristics, we also asked them to take pictures so we could get a better idea of nicotine strength, the type of device they were using, the brand, and all of those things. And so here are some examples of those pictures to help get at those survey measures. So we asked about daily marketing exposure. 17% of the time during the 2-week period, they saw ads for tobacco near their school. 28% of the time they saw tobacco ads in their neighborhood. 37% of the time over the course of 2 weeks they saw ads in social media, and 19% of the time they saw ads in magazines, TVs, or movies. Conversely, 13% of the time they were seeing prevention or health warning messages about e-cigs. It's quite a contrast. Importantly, daily exposure to marketing was significantly associated with willingness to vape and intentions to vape the next day. So here's a slide on the prevalence of reported dual use, and I'll kind of wrap this up here. 33% reported that they were using tobacco cigarettes with vaping nicotine, and 22% said they were vaping nicotine and using cigars. Yeah. So quickly, I'll just show you, we asked 2 measures to see what their intentions were. One is intentions, which is more of a planned concept. You know, they were planning to vape the next day. And as you can see from this graph here, their intentions were higher as the week progressed, indicating that they had higher intentions to use on the weekends. But then we also asked about willingness to vape, which is a little bit different, and it reflects their willingness to use in a given context. So if their friends were using or if they were at a party. And as you can see, the youth here were willing to vape really any day of the week. It didn't matter. They were always willing to vape if the opportunity arose. And then a few implications from our findings. Of course, there are need for policies and interventions to reduce the impact of e-cigarette advertising. I think marketing restrictions for all nicotine and tobacco products, similar to what we have for tobacco cigarettes, should really be considered for retail and online sources. And we need to better understand the relationships between tobacco nicotine marketing exposure and e-cig and tobacco cigarette use, as well as the influences of co-use. And then I see a question here that's asking about whether our methods address biases that may be introduced due to convenience sampling. So I'll talk just briefly about that. We actually sampled youth from a radius of 100 miles from our Louisville office to try to get more of a reach, and we did not allow for friends of participants more than one. They were allowed to refer one friend for our analyses. So we tried not to have too many from the same group or the same community, but
because they all had to be users and 2-week users, that is largely what drove our sample. We also attempted to have 50% of the sample be those that had also smoked tobacco cigarettes in the last 2 weeks. So that drove our sampling. And I think if that's all for questions, then we can move on to Dr. Lin.
Thank you, Dr. Abadi. Hello, everybody. My name is Stephen Lin. I am a research and evaluation specialist here in Jefferson County Public Schools in Louisville, Kentucky. And I have done a lot of previous work in health policy in collaboration with the Foundation for a Healthy Kentucky and quite a few of your organizations. I see that we have crossed paths at some point over the last 5 years. So I'm going to talk briefly about kind of who we are, and a lot of you may be familiar with Jefferson County Public Schools if you are in the region. But if you're outside of our region, we're the 29th largest school system in the country. We have about 81% of all children in the city and the county attending JCPS. We have above 98,000 students in 169 different locations, and we are a minority majority district, meaning we have more non-white students in our district than we do white students. As you can see, we have 125 different languages spoken and a significantly large population of students who are eligible for free or reduced lunch price. Our workforce as a whole district is rather large. We have over 18,000 employees. 6,700 of those are teachers and have master's degrees or higher. And we have more than a tenth of all national board certified teachers. Our district as a whole, you can see we have 90 elementary schools, 26 middle schools, 22 high schools, 14 alternative schools, alternative choice schools, and then 17 state agency schools that may be short-term residential or treatment facilities. So our unit, we are an office within Jefferson County Public Schools. We are accountability, research, and systems improvement. And what we do for the district is we collect data for the district, but also at the school level, and manage the databases, but also the research efforts regarding any reporting. There are 3 evaluators on staff to conduct program evaluations, whether that be internal or in collaboration with partners throughout our city. Additionally, we have trainings for a variety of district and community level individuals on how to obtain information, how to use it, and how to make meaning of it, and also collecting institutional research. Our unit also works with KDE in the assessment and accountability and ensuring that all of the star ratings that you have probably been privy to over the last couple of weeks, all of the information there is there to make that determination. We also have planning efforts and ad hoc reporting for improvement. Particularly, we have a racial equity policy that is in place in the district now to really provide an equitable lens on how we approach what it is, anything and everything that we do, and how we use a racial lens when addressing issues, whether that be evaluation, research, staffing, or the impact on students. And excuse me, there is a link here to a variety of data sources. So once you have this PowerPoint, you can just follow this link and you can access a lot of reports, data files, and so forth. So our approach to evaluation. This is our approach as in our team's approach. So first off, we want to know if something works. So is this program actually doing what it's intended to do and what it's set out and what it was designed for and to meet the goals? Was it effective? So how well does it work, or if it didn't work? So what's the degree of impact we're having with the program that we are looking at? And is it efficient? It's well documented that Jefferson County Public Schools has a $1.7 billion budget. And so we are trying to be responsible with taxpayer money and saying, is this the best way to reach our intended outcome? So if something costs $10 million for 2 years, was that an effective and efficient use of our money? So we also want to understand how to improve. So when we want to understand how to improve, we look at what elements should be changed, should be expanded, or abandoned to support ongoing improvement and positive outcome in our district. So strategic abandonment is one of my favorite terms because it is intentionally, we're being intentional about moving forward, and it's very difficult to do that sometimes. We also want to address specific challenges with our programs and or the process we've used to address implementation throughout the entire life of the program. And we also want to understand what unintended consequences there are within how we address our evaluations in our programs. After we know what to do, or know what the outcomes of our program and understand how to improve, we can create a better plan. So in order to do that, we can create more logic models or programs and activities to actually achieve that plan, or to craft a plan to achieve our goals. We can actually have greater expectations from all of our stakeholders so that we can create more buy-in throughout our community. And a better plan also promotes accountability for our outcomes as well. So a prime example in the time that I have left, I want to kind of walk you through a good example of how we address evaluations of our mental health practitioners. Not necessarily evaluations of the people, but the outcomes associated with the individuals who are providing mental health services to our students. The district committed this year to having 1 mental health practitioner in every single school. So we have right now currently over about 125, 130 practitioners in our schools providing mental health services to students. And that should be expanding to every school here soon. So in this evaluation, I met with the program owners, and I say program owners, I mean the people overseeing every mental health practitioner, and saying, what are we planning to evaluate? Is it their performance? Is their effectiveness? Is it student outcomes? What is it? What are we trying to understand from having a mental health practitioner, whether that's a LCSW, MFT, and so every other practitioner. So what are we trying to understand? What are the key questions that you want to answer when we talk about evaluation? And how and when will these be answered? What are the specific stages, and what am I responsible for? What are you responsible for? And what are the people implementing the program responsible for? And what are we going to do with this? So who's going to use the evaluation results, and what are we going to do with it? What decisions are going to be made? And then when do we need it completed? So for this, to understand the effect mental health practitioners have on students in our schools, we wanted to have data before, during, and after. So what does the information we have look like before we start implementing this program? During, are we moving in the right direction? So how can we monitor the implementation of these individuals and the services they're providing throughout the school year to show improvement efforts in students? And then after the school year, did we have an impact on our specified metrics? So really having a good foundation and plan can actually help drive this evaluation home. So this Albert Einstein quote really hits home with me, because how do we know we're moving the needle forward with mental health services in students? It's very difficult to really understand have we actually prevented a child from doing something that could be harmful? Or how do we even know that a student is actually moving forward due to the services we provide? I was talking to one individual the other day, and she asked me, she goes, Stephen, I can't measure how many times I have helped a student prevent an attempt at suicide. And so it's very difficult to understand the challenges that we face when evaluating the services we're providing to students and the outcomes that are associated with that. So, significant challenge. Research has shown that if you can track a student and provide services to students for a minimum of 3 semesters, so a year and a half, so that would be fall, spring, and the corresponding fall, or spring, fall, spring. So a minimum a year and a half. If we provide the same services or tailored services to that student in a similar dosage for every single semester with a consistent mental health practitioner, we can actually start identifying some metrics that could show improvement in academics and behavior. So, like I said, it's very difficult to understand how many times you've helped prevent a student from harming themselves, but how do we understand what we can control, and that's attendance in school, behavior in school, and are they engaging more positively in the classroom? So our study looked at actually students with 3 consecutive semesters, 4 consecutive semesters, 5, and 6 consecutive semesters. So we actually created 4 different cohorts with a repeated measures model of understanding how do we look at attendance and behavior metrics and moving the needle forward throughout the year, what types of services are being provided, who is making the referrals, and what techniques are being used to help the students throughout the year. And then afterwards, we're going to assess and determine, are we actually moving the needle on attendance and behavior? So using that type of model, we can look at different points in time, whether that's 3, 4, 5, or 6 semesters. So if you see a student for 6 consecutive semesters or 3 full school years with the same practitioner providing tailored services with the same dosage, we can actually start to see improvement in these metrics. So to revisit this, and I'm going to try to wrap up here so Dr. Johnson has some time. To revisit this, we basically said, how do we know our investment in mental health services for our students is effective? So what types of services are we providing, and can we help improve attendance and help improve behavior outcomes throughout the school year? And then what are the key questions that we need to answer? So are students improving over time? When do we need these? How do we need these? Well, I provide this report annually with different cohorts of students. So the students have to be consistently enrolled in our programs and looking at how they fare with those mental health practitioners over multiple years. And lastly, these reports have been shared with the decision makers, whether that's the superintendent or his cabinet and the Board of Education, of saying, here's how we're doing, here's where we are, and if we're showing positive effects, is there positive return on investment? Whether that's a $5 or $10 million investment in personnel, is that an effective use of our money to help students and their mental health and improve their mental health while they're in our schools? I know I ran through that fairly quickly, but my contact information is here if you have any follow-up questions, or if you want to reach out to me offline, you may do so as well. So I believe Dr. Johnson.
Thank you very much. My name is Chris Johnson. I'm a professor and chair of the Department of Health Management and System Sciences here at the University of Louisville, but I come to you today in my capacity as site director for something called the Center for Health Organization Transformation, and also in my role as urban policy chair here at the University of Louisville. My background is that I am an organizational health services researcher, and what that means is that I use organization theory and organization design to help organizations understand how they can impact access, cost, and quality within healthcare. So to give you a lens on how I view the problems and phenomena that I find interesting, I'm very much based within organizations and trying to understand how organizations can improve, what factors are inhibiting organizations from improving, and all those kinds of things. And so today we're going to chat a little bit about this thing called organization evaluation. What does it mean? Why do we do it? What are its key components? We'll talk about a couple of methodologies that we use to understand how organizations are performing and how we apply those to understand and analyze different problems that are occurring within organizations. And then we'll talk about the center, which is designed essentially to do the evaluation that we're going to be talking about. It's a center that's part of the National Science Foundation, whose real aim is to understand and evaluate the healthcare industry. Also, we're going to discuss a specific problem related to organization and evaluation that's centered around something called employee inclusion and well-being. And we're going to find out that by the end of this little presentation that there is an economic cost to not being inclusive and not encouraging employee well-being that a number of organizations are concerned about. And one of the things that this center does is help them figure these things out. So here's a quick and dirty definition of what organization evaluation is. It is this process that is really twofold. One is we're trying to understand how an organization functions, so to understand the relationships between different components of the organization and how it is producing or not producing the results that it needs. And then once we've identified places where these things are not doing what we want them to do, how do we evaluate interventions that are then designed to improve the performance of the organization? So really those are the two components that will be discussed throughout the rest of this presentation. So we're at a more macro level, how is the organization performing? And then at a more micro level, how do we design interventions to impact organizational performance? MITRE is a organization that has a large number of federal evaluation projects. They also have a number of public-private evaluation projects, and this is an engineering model of how you could think about organizational assessment. It's a multi-phase process where you begin by, doing the context information gathering about how the process or how the organization is functioning. Then you identify the data that you want to gather to understand the context of the organization and targeted data. And then you identify strategic changes that you want to make within organizational performance in order to execute plans, and then you follow up and look at how you're going to evaluate the change priorities that you've identified as an organization. Now, there are other models to use, and if you've studied quality management or anything like that, you might have heard of things called Six Sigma or Toyota Lean or PDSA cycle. There are a number of different models that you can use to do organizational evaluation, and this is just one. But when we have this structured way of thinking about how organizations are performing or not performing, what we found is that by following these processes, it helps you to make meaningful change within these organizations. Because I'm in a Department of System Sciences, we like to think of organizations as part of a system of activity, and this Burke-Litwin model is a way that we kind of think about, if we're going to think about what's producing organizational performance, what are the key components that we have to understand within the organization, and if we're tweaking one part of the organization, how is that going to impact another part of the organization? And so, because we're in healthcare, we know that the external environment has a great deal of impact on the way that organizations are performing in healthcare, whether or not it's regulatory changes or insurance changes or those host of different kinds of things can impact us. And then how do those environmental changes impact the way that work is done within the organization at both the upper levels, more macro levels of mission and strategy and leadership and organizational culture, and then how does that work, in the lower levels of the organization when we're looking at employee performance and the overall culture of the organization, all those kinds of things. Well, fortunately, the National Science Foundation has recognized that these are the kinds of things that will help the United States with their consideration of how to improve industry performance across the country. This particular program of the National Science Foundation is part of the Industry University Cooperative Research Center program. There are multiple centers across the United States that include organizations that study all kinds of different kinds of industries. So there's an IUCRC for the best battery or IUCRC for forensic science. We happen to be the only IUCRC that's funded to study healthcare-related problems in this particular funding stream. This is our mission, to advance the knowledge and practice of transformational evidence-based management and clinical practice, and that means that we do a lot of evaluation of all kinds of processes and activities within the companies that are members of the center. This is the way the center works, and our research center is funded by contributions from our industry partners. And our industry partners make up something called the Industry Advisory Board, and they identify the evaluation projects that they want us to do within their companies, and the university sites put together research teams that then go into the organizations and execute the evaluation projects. All these projects are industry-driven. They come to us with ideas, and we talk to them about how we can help them. And then we go into the companies and help them solve the problem and hopefully produce some return on investment for the activity. Here are the current research themes within the center. So we have a number of projects related to population health evaluations, access to care, care coordination, analytics, and innovative technology, and patient experience. All of these have multiple projects. All of these are evaluations in some way, shape, or form. All of these are driven by our industry members who want us to help them figure out ways to improve these 5 core areas. So these are the university sites that are members of the center. What the university sites do is make the research teams that go into the organization. So if a company has a problem with, for example, a database structure, they want to create a better database structure for their organization, then I would go to the Speed School here at the University of Louisville. I would identify a principal investigator for that particular project. A number of students would be the workers for that particular project. and then they would go into the organization and help that company solve the data problem that they're having. And we do that locally to find experts. We do this across university sites to find experts, all of which are going to be part of the evaluation teams. Give you an idea of the organizations that are members of the National Center. This is a small list of all the different companies. As you can see, we have a wide gamut of different kinds of healthcare organizations. Essentially, our task is to cover the healthcare industry. So we have technology companies, your traditional hospitals, et cetera, and so forth. Here's an example of some of the projects that are currently running. And as you can see, these are projects that are evaluating all kinds of different types of interventions within different settings to see what the impact of that intervention was on the performance of whatever it is that the organization wants us to examine. Locally here in Louisville, these are our partners, and so the projects that we do here locally are the projects that these companies drive us towards in terms of things that they're interested in having solved. And then these are some of the projects that we have currently operating with our partners. And we're going to talk about one of those projects in a minute. But these are the kinds of things that our companies here in Louisville or that are members with our site in Louisville are tasking us to solve. So each of these projects has a research team, a PI, a budget of $50,000 to $100,000, and there are annual projects. And so we do the projects at the beginning, we do the evaluation, and report back to the companies about what we find. Now, returning back to the Burke-Litwin model, one of the things that organizations now in 2019 are very concerned about is inclusion, because inclusion and equity within organizations has been shown to have an economic impact. And so what I'm going to do for the rest of my time is talk about a particular evaluation project that's very focused on sort of the lower level of the organizations. How do we introduce interventions to improve the work climate, to impact the motivation of people that work in companies, and also how do we meet the individual needs and values of the people that are making up the employee workforce for these healthcare organizations. To give you an example of the economic considerations, a number of consulting firms are doing analyses to calculate, what is the impact of not being inclusive within organizations, not considering the makeup of the employees, whether or not it be along the lines of their sexual orientation, or how do we measure the helplessness or the depression or the disparities that exist within organizations in terms of how employees are treated as part of the workforce. And so this problem is so important that there was, at the National Academy of Management meeting, which is a national meeting that includes all the business schools, faculty across the world, the main focus of that conference was on research about inclusion and equity within organizations. So this is a big money economic driving topic that is being considered by these companies. So Deloitte has done sort of frontier type work and looking at what the impact of inclusion is on the industry at large, and so they issued a report recently discussing how inclusion impacts organizational performance, just to give you an idea of how important these kinds of issues are. So this is one of our projects that's currently being done in conjunction with a national home health agency. This home health agency wanted to know how it could be more inclusive to its employees, because the home health company employs a lot of folks who are not from the states that they are assigned to, or not even from the United States. And so there was a great deal of concern about, what could they do to, what kind of intervention could they design to improve how inclusive their employees felt. And so we've been doing pilot work with one company that's grown into a much larger study where we're spreading out the design, the research design, to other companies. And so this is on the screen is an example of the kind of organizational evaluation study that we're doing within the organization. So we have a specific timeline. We have the kinds of measures that we need to measure. We have surveys that we do in order to gather information pre-post interventions in order to see the impact of the intervention. And we also have a key economic component where we actually have to go and show what the economic impact of having more inclusive employees are within the organization. So that's the end of my talk. If you have any questions, you can click on these links or contact Melissa Egan, our program manager. And now we'll turn it over back to the Foundation for Health Kentucky.
Thanks so much, Dr. Johnson. I thank each of our presenters here this afternoon. Dr. Johnson, who's at University of Louisville and also is the endowed chair at the Foundation for Healthy Kentucky for Urban Health Policy. Dr. Stephen Lin with Jefferson County Public Schools. He reminds us that if you want to find out some of the results, then please connect with him about his projects via the web link he offered in his presentation slides, and Dr. Melissa Abadi with PIRE. So we see three different approaches: surveys, program reviews, looking at the organization system, and it can offer us three different things. We can describe what is happening in our community with respect to e-cigarettes, as Dr. Abadi showed us, give us evidence on areas for improvement, as one of the goals that Dr. Lin shared with us, and also can help us understand equity in our organization, as Dr. Johnson described in the last example. I will send you a survey because we're all evaluators here. Please, this afternoon, in your email box, you'll see an email from me. I would love for you to take less than 3 minutes to give your feedback on this webinar today, and also suggest topics for future webinars. It's important to this Health for Change training series that the Foundation for Healthy Kentucky sponsors. If you're one invitation also, the Louisville Lou Eval, it's hard to say, Lou Eval, it's a new group that's just been put up. Rebecca Hollenbach at the Office of the Mayor in Louisville in performance improvement, and a number of other people are involved in a local evaluation group. Everyone's welcome to join that group. Just send me an email. I'll get you connected to that organization. Dr. Lin was the one that named that group, Lou Eval, creative. Just getting started here in Louisville. Also, if you're not following the Foundation for Healthy Kentucky on social media, I invite you to join us on Facebook, on Twitter. I tweet out of KY Health Facts for the Foundation, and also run the Foundation's data website, KentuckyHealthFacts.org. Again, thank you to our presenters today, our Kentucky-based evaluators. Thanks for each of you who joined us here on the webinar today. I look forward to hearing from you. I'm glad to answer your questions, and I'm glad to support all of you working to improve the health of Kentuckians. Thank you for joining us today.